Well, let's go ahead and get started with for sake of time and for Lacey's time. So, hello, everybody. My name is Diane Faison-Rowe, and I am a member of the outreach team here at SunCloud Health. Thank you for joining us today for our National Clinical Collaborative Learning Series. SunCloud provides the full continuum of care from residential services to PHP and IOP for adults and adolescents, focusing on customized and integrative care for eating disorders, addiction, mood disorders, and/or trauma. We have locations in Northbrook, Lincoln Park, Naperville, and Madison, Illinois. For today, just a little bit of housekeeping. For today's CE, you will receive an email including the quiz and the survey. So complete these to receive your CE certificate by email. And you should expect to receive your CE certificate within the next 7 days. You will also receive a copy of today's PowerPoint in the email, along with a link to leave a Google review of your positive experience with SunCloud Health's continuing education opportunities so far. We also will have links to the registration for the next two CE events. We have some exciting new other topics for July and August at the end of this presentation. So please register for our free CE opportunities with SunCloud. But today's presenter is Dr. Lacey Lemke. She is our Vice President of Clinical Services at SunCloud Health. Dr. Lemke is a licensed clinical health psychologist and currently serves as the Vice President of Clinical Services at SunCloud Health, where she provides strategic oversight of clinical programming and advances the integration of medical and behavioral health care. She is a recognized leader in the treatment of eating disorders and complex co-occurring conditions. She completed her doctoral training in clinical psychology with a primary care health emphasis at the Adler School of Professional Psychology, and went on to complete both her pre-doctoral internship and postdoctoral fellowship with Ascension Health. There, she received advanced training in the treatment of eating disorders and self-injurious behaviors, and worked across pediatric subspecialties, including endocrinology, neurology, and adolescent medicine. So Dr. Lemke is known for her collaborative leadership and commitment to clinical excellence, delivering evidence-based compassion and patient-centered care. Her work is grounded in helping individuals access the most appropriate level of care while fostering meaningful, sustainable change. So we are so honored to have Lacey presenting today. And without further ado, I will go ahead and let Lacey take over for her presentation, One Client, Many Models, Integrating CPT, TF-CBT, and RO-DBT through a Transdiagnostic lens. So thank you. Let's welcome Lacey.
Thank you so much, Diane. Hello, everybody. Thank you so much for joining us. I'm super excited to be hanging out with you guys this afternoon. We got a lengthy presentation, so hopefully you learn a ton. I do ask we save questions till the end. I just want to make sure I get through all of the material. And then if something happens and we don't get an opportunity to have a question answered, you guys will have my information, so you can reach out and we'll make sure those questions get answered. But I'm excited to be here with you all. So this training today is truly meant to be a clinically practical, evidence-informed integration conversation, if you will. My goal here is not to create a new branded protocol, but truly to help providers think a bit more flexibly, specifically when we're talking about mechanism, when we're talking about sequencing, fidelity of your treatment, and truly patient complexity overall. So when we look at cognitive processing therapy, trauma-focused cognitive behavioral therapy, and radically open dialectical behavioral therapy, these modalities truly all offer a different doorway, if you will, into suffering. CPT through trauma-related meaning making, TF-CBT through skills and narrative and exposure and a focus on relational systems, and then RO-DBT through overcontrol, right? And looking at social signaling and openness and flexibility. So we're going to talk today about how to enhance your clinical practice in utilizing various modalities together and using them in a very thoughtful and methodical way. These particular modalities complement each other very well and work pretty beautifully together, which is why I selected these guys to talk about. So Let's get into it. Our learning objectives today, we are going to define a transdiagnostic mechanism-based case conceptualization. We're going to compare the core targets of these modalities. We're also going to identify where trauma processing and emotion regulation and over-control interventions overlap and also how they diverge too. We're going to talk about sequencing and using sequencing questions to really determine what to treat first and next and later in the therapy journey. And then we're going to apply an integrated formulation to a complex case presentation. So I think it's really important as providers, we focus on not simply selecting techniques and interventions because they're our favorite or because we know them really well. Our job is to truly assess the function of symptoms, right? And match interventions to mechanism. So this training today is going to assume a foundational knowledge of trauma informed practice. And we're going to focus on how to organize complex treatment when we have clients who present with trauma histories, when we have clients that present with eating disorders and anxiety, perfectionism, shame, or interpersonal disconnection. Okay. So one of the biggest challenges in real world clinical work is that our patients rarely present with one clean, isolated diagnosis, right? In training, we often learn treatments in silos, right? We learn in graduate school, perhaps, that cognitive processing therapies for PTSD, right? And trauma-focused CBT is for trauma, and RO is specifically used for overcontrol. But actual patients who step into our office or step into our programs rarely fit those neat buttoned up categories, right? Especially in higher acuity settings, we are seeing individuals present with layers of overlapping symptoms and vulnerabilities all at the same time in many cases, right? So a patient may come in with a trauma history, but they may also be struggling with eating disorder behaviors or self-harm and substance use and experiencing significant relational disconnection at the same time. So these presentations are complex. We know that, right? They're very dynamic, but often they're very interconnected. And when we try to conceptualize treatment through simply looking at diagnostic categories, we as providers can become very overwhelmed, right? Because one diagnosis is going to suggest one protocol and another diagnosis is going to suggest another. And we start to feel like we're constantly switching frameworks, right? Instead of just treating the person in front of us. And so that's where transdiagnostic treatment and utilizing a transdiagnostic lens becomes very valuable because rather than focusing on surface level symptoms, we start to ask ourselves the question, what function is the behavior serving, right? I oftentimes will say in trainings that my favorite question to ask an eating disorder patient is, tell me what's good about your eating disorder. Sell it to me. And what am I getting at when I do that? I'm getting at the function. I'm getting at the why, right? That's the golden nugget. That's what we want because once we understand the function as clinicians, that's where we can hone in, right? So let's talk about what mechanism-driven care even is, all right? Traditionally, I would say our field, again, has been organized really around those diagnostic categories. And our central clinical question oftentimes is, well, what disorder does the patient have, right? Now, that approach certainly has value, right? Our diagnoses help us with communication. They help us in research. They certainly help us with insurance authorizations, right? They can help us with treatment plan structure for sure. But in practice, diagnosis alone, it often fails to fully capture what is actually maintaining a person's suffering, right? So think about even your own practice. You can have two patients that are in your office or in your program that both meet criteria for PTSD, right? But one of those individuals is primarily struggling with emotional overcontrol, and they're struggling with chronic emotional inhibition when the other person who also is diagnosed with PTSD is struggling more with impulsivity and being highly reactive and experiencing emotional flooding, right? Diagnosis is the same, but the mechanisms that are driving the distress are very different. So when we look and work to conceptualize our patients from a mechanism-driven care model, we're asking a different question. We're asking what processes are actually maintaining the suffering across presentations. And when we take that subtle shift, everything changes clinically, because then instead of focusing primarily on just symptom clusters, we're now focusing on patterns, right? We're focusing on patterns of avoidance. We're focusing on patterns of cognitive rigidity, of the perfectionism, of the hypercontrol. And what's important to note is that typically mechanisms will often cut across multiple diagnoses, right? So think about perfectionism, for example. Perfectionism may show up in eating disorders, but it also may show up in OCD and trauma and anxiety and depression. Think about emotional avoidance, right? Emotional avoidance can drive PTSD symptoms, but emotional avoidance can also drive substance use, right? And can also drive self-harm or restrictive eating, right? So when we work to identify shared mechanisms, we're really working to enhance our treatment and make it more integrated and more precise, right? And this, again, is especially important in higher acuity settings, right? Where those patients rarely fit into that category or box, right? The visual on the right of your screen really works to reflect this progression, if you will. So again, moving away from focusing solely on the symptom and instead asking the bigger question, right? What is the mechanism? What is the function of the behavior? What target treatment logically follows from understanding those things, right? And this framework is going to allow us to integrate therapies very intentionally rather than just combining different interventions randomly, right? Lastly, I think it's important to focus on, mechanism-driven care. It really works to improve clinical flexibility without sacrificing evidence-based practice, right? So it's important to note we are still grounded in empirically supported treatments, but we're just selecting interventions based on the process that's maintaining the suffering, right? Versus just like rigidly adhering to the diagnosis alone. All right, so let's talk a bit about what does transdiagnostic even mean, right? When we use the term transdiagnostic, we're referring to an approach, again, that is looking beyond the individual's diagnoses and really working to hone in on those underlying processes that cut across different disorders. Remembering too, and again, transdiagnostic frameworks do not eliminate diagnosis. It's not anti-diagnosis, right? But it just adds another organizing layer underneath a diagnosis, right? What shared processes are showing up across the presentations? Because when we look clinically, again, many disorders maintained by overlapping mechanisms, right? So although, again, those surface symptoms may look different, the mechanism beneath them are oftentimes remarkably similar. And again, that's clinically powerful. That's very useful for us. When we can identify the shared maintaining processes, we can target them more directly and we can target them more efficiently, right? So transdiagnostic frameworks really work to create coherence, if you will. And again, it just totally allows us, in my opinion, to treat human suffering in a way that's more individualized to the person sitting in front of us. So here you're going to see several of the most common transdiagnostic mechanisms we see across clinical populations, right? These are not simply just symptoms. These are the processes that are actively maintaining suffering over time. It's important to note that these mechanisms will often interact with one another and in some ways truly create a self-reinforcing kind of cycle, if you will. And that oftentimes keeps folks stuck, right? You're going to hear us return to these throughout the entire presentation, but let's go over these together. So the first mechanism listed here is avoidance. Avoidance is, in my opinion, and the literature also supports, it's one of the most robust maintaining factors, I think, across psychopathology, right? In the short term, avoidance works. We know it works. It reduces distress temporarily, and that's exactly why folks keep using it, right? A patient may avoid trauma reminders, right? They feel that immediate relief. A patient may restrict their food intake and temporarily they feel much more in control. Someone may withdraw socially, right? And then they are avoiding vulnerability, right? They're avoiding rejection and it makes them feel comfortable. But we know as clinicians that long-term avoidance actually prevents corrective learning, right? Our nervous system, when we consistently avoid, it never gets the opportunity to learn, hey, I can tolerate this, right? Or this memory is painful, but it's survivable, right? So while avoidance decreases distress in the moment, it often maintains or even strengthens symptoms over time. Okay. The next mechanism is threat sensitivity, right? When threat sensitivity is elevated, our attention becomes really focused on danger, on certainty, control, right? And clinically, this can look like patients in your office or in your program who are struggling with hypervigilance, right? Or struggling with obsessive thinking, struggling with restrictive eating patterns, right? The brain will essentially shift into like a chronic protection mode, if you will. And this is especially common in trauma-related presentations, anxiety disorders, OCD and eating disorders, right? Highly over-controlled coping styles, if you will. The third mechanism here is shame. Shame is incredibly powerful because shame doesn't just say, I made a mistake, right? Shame says there's something fundamentally wrong with me, right? And when shame becomes central, people will often move towards secrecy. They'll move towards more self-attack, right? More withdrawal, more disconnection. And here we might start to see folks try and conceal their symptoms, right? These are your patients who you work with that are really harsh when it comes to self-criticism. They may struggle with receiving care or feeling like they deserve care, right? Shame is oftentimes deeply tied to trauma. It's also deeply tied to attachment injury as well, also attached to eating disorders, self-destructive coping behaviors, right? So we see it pop up a lot across presentations. Next is cognitive rigidity, right? That's referring to individuals having a difficulty adapting to beliefs, right? To different perspectives, to different behavioral patterns once their patterns have become established, right? When we talk about trauma meanings can actually become very rigid life rules, right? Things like I can't trust anyone, things like my worth depends on my performance, or I must be perfect to be accepted, right? Over time, these beliefs that develop, they stop functioning as just like temporary protective kind of adaptations, and instead they become quite restrictive frameworks for living. Right. And then lastly, we have emotional inhibition. When emotions are consistently suppressed, right, or minimized or hidden, folks really lose opportunities for corrective relational experiences. So they might appear highly functional, right, externally, but initially, these are the folks that are experiencing profound loneliness, right, and experience disconnection. And this is particularly important when we're talking about RO-DBT and when we're looking through an RO-DBT conceptualization, looking at excessive self-control and emotional inhibition and how that can interfere with things like intimacy and with things like flexibility, right? So again, what makes all of these mechanisms so clinically important is that they cut across diagnoses, right? A patient can present with PTSD, anorexia, depression, substance use, or anxiety, right? But underneath, we may still find the same maintaining processes, right? Avoidance, threat sensitivity, shame, rigidity, emotional inhibition. And this is why mechanism-driven treatment can really create greater cohesion in care. Because as you work to target that underneath and target those mechanisms, you're actually targeting multiple symptoms at once. Okay? So this slide just illustrates, if you will, how these maintaining mechanisms can interact with each other and present like a self-reinforcing loop. So especially in complex clinical case presentations, this is just an example. Many clients, right, may begin with some form of trauma learning, or chronic invalidation, right? And that's going to increase a sense of threat sensitivity, right? The world begins to feel unsafe, unpredictable, right? Emotionally overwhelming. And in response to that, individuals may, oops, excuse me, let me go back. Whoop, whoop. There we go. And in response to that, individuals may then start to exhibit avoidance, right? Or excessive control strategies to reduce their distress, right? So that can look like emotional avoidance. That can look like perfectionistic tendencies starting to develop. That can look like restrictive eating, compulsive behaviors, right? And over time, once we see that avoidance start to take control or the focus on control take over, emotional inhibition can develop, right? Feelings become suppressed rather than expressed. And so that authentic connection with folks, it's going to become more difficult. That inhibition will then lead to isolation and lead to shame, right? And patients or individuals you're working with may start to withdraw from relationships, start to conceal their distress or hide that they're struggling, right? Experiencing reinforcing beliefs like no one understands me or I'm too much, I'm a burden, I have to manage this all by myself, right? Ultimately, this entire cycle is going to reinforce symptoms, right? And that strengthens that original trauma-based learning. It just keeps the loop going. So the clinical takeaway here, you guys, is at the bottom of the slide, truly. We don't always have to dismantle this entire system at once. That's very overwhelming to think about as a clinician, right? But instead, it's important that we look where the loop is most movable today, right? And that's going to be different patient to patient. So for one patient, that might mean targeting the avoidance first. For another, we might want to start with increasing emotional expression, okay? For another, we might want to really focus on reducing shame, and we want to work to enhance relational connection or help the patient engage in some cognitive restructuring, okay? So important to note that we truly want to focus on what we can work with today, right? Versus how can we dismantle everything at once. All right, so this next section, what I want to do is really level set and make sure we're all on the same page when it comes to our own understanding of these trauma-focused models. So we're going to take a look at cognitive processing therapy, at trauma-focused CBT, and then later at RO-DBT, just to get an understanding and make sure everyone at the foundational level has an understanding of what these models look at, how they're similar, and how they're different, okay? So let's start with cognitive processing therapy. Cognitive processing therapy, it is a trauma-focused cognitive therapy, right? It was originally developed for PTSD, but its framework is highly applicable across many trauma-related and just transdiagnostic populations and presentations, okay? So at its core, CPT is going to focus on how trauma changes meaning, okay? The central idea is not simply that something painful happened, right? It's more. It's really working to understand that the trauma someone experienced altered the way that that person understands themselves. It altered the way the individual understands others and just their world, right? So after trauma, individuals will often develop very rigid or distorted beliefs, right? So those beliefs may be, I am unsafe. I can't trust anyone. The world is dangerous, right? And in CPT, these are referred to as stuck points. And we're going to expand a little bit more on stuck points in just a bit. But the core CPT question becomes, what meanings did the individual make from what happened to them? And how are these meanings continuing to shape their current functioning, right? The goal is not to erase the trauma or convince someone that the event was okay. Instead, it really hones in on helping individuals examine whether the beliefs that they're holding are accurate, whether those beliefs are balanced, and whether they're flexible, whether they're helpful or not in their present day life. So the visual on your right that you'll see just reflects how first in CPT, we're going to identify the meanings attached to the trauma. And then we move to really exploring stuck points that are maintaining distress. And then through cognitive restructuring and processing, clients will begin to develop more balanced beliefs. And ultimately, that cognitive flexibility will really support a more adaptive, flexible living. Okay. Even working with highly complex clients, CPT really provides a very structured way to understand how trauma-related beliefs continue to influence one's life, right? And impact their functioning. So I want to talk a bit just about stuck points because that's one of the central concepts in CPT. Stuck points are, you can describe them as very rigid trauma-related beliefs that folks get emotionally trapped in, right? They get trapped in the meaning that they made from traumatic experiences. So it's important to note that these beliefs typically develop as attempts to make sense of overwhelming events, right? In an attempt to regain control or even protect against future harm. But the problem is that over time, these beliefs become overly absolute and very generalized, right? So clinically, stuck points will typically sound really black and white. So when you have someone talking to you saying, well, I should have known, or I can't trust anyone, it was my fault, right? These beliefs for the individual may initially function as kind of protective adaptations, right? But eventually they begin actually maintaining avoidance and maintaining distress for folks, getting in the way of relational connection. And so in CPT, the goal is to help individuals identify those beliefs and really examine the evidence for those beliefs, but also examine the evidence against them and begin really moving towards, again, more balanced and flexible thinking. Okay. From a transdiagnostic perspective, many of the themes that we see in stuck points, right, that typically are organized around themes like safety and danger, trust, power and control, self-blame, we see those overlap across other disorders and across other treatment models, right? So think about it. Think about your own practice, right? Rigid control beliefs, right? What diagnoses can those overlap with, right? The eating disorders, right? Other over control, OCD, shame stuck points. Think about shame-based stuck points, right? Those could fuel self-harm, right? Those could fuel social withdrawal, right? The goal with CPT, though, it's not to just force positive thinking, right? It really is to work with patients and allow them to start develop beliefs that truly are more accurate and that are more flexible in nature. So these terms are also really prevalent. There are three key concepts in CPT that you'll hear, and truly they help explain how folks cognitively process traumatic experiences and situations. So the first is assimilation, and that is referring to when someone they alter or kind of interpret a traumatic event in a way that allows like pre-existing beliefs to remain intact. Okay, so oftentimes this involves a lot of self-blame. So think about patients who've been sexually assaulted that you talk to, and you hear them use the statement, well, it happened because I should have known better. Or maybe if I had acted differently, or if I didn't do X, Y, and Z, it wouldn't have happened. Right? So the individual is trying to like force the trauma to fit some prior beliefs that they have or had about safety and about fairness and about personal responsibility, right? And this will create an illusion of control for the person, right? But it oftentimes will maintain guilt for them and it will maintain shame for them and this distorted responsibility, okay? The second concept you hear in CPT is called over-accommodation, and that's going to occur when a person will change their beliefs a bit too broadly after trauma, right? And that usually will lead to very rigid and generalized conclusions, right? So no one can be trusted, or I can never be alone with someone of the opposite sex, right? I must stay in control at all times, right? These beliefs are understandable, right? If we think about the way that they were derived and the trauma that someone experienced. But again, they become overly absolute, right? And they become pretty restrictive. And so over accommodation oftentimes contributes to chronic avoidance in people, and increased emotional inhibition, and then two, just relational difficulties, as I'm sure you can imagine, right? The goal of CPT is to move towards accommodation. And accommodation is simply referring to like balanced belief change, okay? So rather than denying that the trauma ever happened or allowing it to define them or their entire self, the individual will start to integrate the experience in a more flexible way. So what does that look like? It can look like an individual moving towards a place where they may say, what happened to me was harmful, but it was not entirely my fault, right? Or some people are unsafe, but not everyone is unsafe. So you see that shift, right? From the black and white, overly absolute style of thinking. Clinically, this is where we start to see greater flexibility, right? And we move towards, as you can see, we move towards flexible living, right? We move from the stuck beliefs or stuck points, excuse me, into more balanced beliefs and into that more flexible living style. So from a transdiagnostic perspective, CPT is useful because its mechanisms that it targets are not just limited to PTSD, right? Think about the different mechanisms that you've heard about, that cognitive rigidity, the shame, right? The guilt, the threat appraisal, right? The meaning making. All of these mechanisms show up in many different presentations. They show up in eating disorders. I can tell you that after working with eating disorders for as long as I have. They certainly show up in depression and anxiety, right? And they certainly show up in trauma presentations. So think about, you may have an individual who struggles with food-related behavior, right? But the belief underneath that might be, my worth depends on control, right? Or my body is unsafe. And this is where CPT, for example, can really work to create some broad movement there, right? Because when the organizing belief shifts, several symptoms may soften, right? They may soften because they were all serving the same meaning system, right? So CPT is really great. It's especially important when trauma-related beliefs are really running the show for someone and really at the center of gravity for the person that you're working with. Okay, so let's move on and talk a bit about another trauma intervention, trauma-focused CBT. Love trauma-focused cognitive behavioral therapy. Many of you may be familiar with it, but TF-CBT, it's a phase-based trauma treatment. It was originally developed for children and adolescents, yes, but many of its principles are highly applicable, in my opinion, and looking at the literature across developmental stages and treatment settings. When we train our staff at SunCloud, all of our staff, regardless if they treat adolescents or adult, are trained on trauma-focused CBT. One of the strengths of trauma-focused CBT is that it really works to combine multiple evidence-based elements into a very cohesive framework. And the whole goal of TF-CBT is to increase safety for patients, improve emotional regulation, allow patients to process trauma memories, and then reduce the avoidance, right? So unlike approaches that are going to move more immediately into the trauma processing, the good thing about TF-CBT is it really focuses on building a foundational kind of level of coping and regulation skill building first. And what that does, it's great because it helps really create a sense of emotional safety and stability for the trauma work to happen after a little bit later, right? More safely, more effectively. When you talk about TF-CBT or you hear about TF-CBT, oftentimes you will hear the term practice. Practice is basically the framework that serves as like a roadmap, if you will, for trauma-focused CBT. So the first component is psychoeducation and caregiver support, right? Really working to provide that psychoeducation. When we do that, it really reduces shame. It helps to understand trauma in a very non-pathologizing way, which is fantastic. It works to increase predictability. It helps normalize symptoms, right? And when appropriate, caregiver involvement is really heavy here in the initial phase of TF-CBT. And that really focuses on that relational component and building relational connectedness. The next phase, the R, is relaxation and affective modulation. So this is when we move from psychoeducation in TF-CBT into a phase that really helps patients learn regulation skills, right? And how to increase emotional tolerance and nervous system flexibility overall, right? So this could be mindfulness techniques when you work with patients on grounding, or you're teaching paced breathing, or identifying emotions. Here's where we may introduce some distress tolerance skills, right? Body-based regulation strategies are really cool here. These interventions and at this stage are really important because trauma, as we know, oftentimes really disrupts emotional regulation, right? And it creates, in some cases, hyperarousal where folks will be really reactive, right? Or it can do the opposite and create emotional shutdown. So this is really helping to prepare folks as we move into the next phase, which is really working on cognitive coping and cognitive processing. Okay, that's the C. So cognitive coping and cognitive processing is where we pull out that cognitive behavioral therapy roots, and we start working with patients on how to learn how thoughts, emotions, and behaviors interact, right? This is where we really start to work there. And we focus with patients on trauma-related beliefs, and we explore their appraisals here, their beliefs that they have about safety in particular, about trust, right? And this component is going to overlap really nicely with broader cognitive and like transdiagnostic approaches because truly it targets the maladaptive, if you will, meaning making and the cognitive rigidity, right? So as we move from this, we move into the next component, which is trauma narrative and gradual exposure. Okay, that's where the T comes in, trauma narrative and gradual exposure. This is where frankly, it's one of the most clinically significant phases of TF-CBT. And this is where patients gradually organize and process and start to narrate their trauma, right? They've experienced the psychoeducation. They've experienced the skill building needed to be able to sit with this process, right? And develop the emotional regulation skills needed. They've gone through understanding and starting to identify beliefs. Here's where we process in a very safe and structured way, right? Exposures are done very incrementally, right? The goal is not re-traumatization. We all know that. It's integration and working to reduce avoidance. And then the final phase, if you will, is noted as conjoint work, integration, and safety enhancement. And that's where folks really work to apply their new skills relationally, right? Strengthen their communication, plan for how they will be successful in the future. Okay, so that's kind of TF-CBT in a nutshell, using those practice components. Let's talk about some of the mechanisms that trauma-focused CBT targets. So trauma-focused CBT is going to target certain mechanisms, and that's why the model works so effectively across trauma presentations. One of the major mechanisms addressed is avoidance, right? It's avoidance. We know that trauma teaches individuals it's safer to avoid reminders, avoid emotions, avoid memories, right? That can stir up distress. Trauma-focused CBT works to reduce the avoidance gradually through the trauma narrative work and through the exposures, right? Another major mechanism that's targeted here is emotional dysregulation, right? And we talked about this already. Trauma disrupts a person's ability to effectively regulate themselves, right? So trauma-focused CBT is doing this because it's teaching, or it's honing in on this because it's teaching those skills, right? It's teaching the affect modulation, the grounding, the coping strategies. The model also really supports cognitive change. It's a cognitive therapy, right? And it really helps individuals understand their beliefs related to danger and their beliefs related to shame, their beliefs related to trust, right? And it really helps to adapt these interventions to a patient's developmental level so it can make complex trauma processing more accessible, right? And easier and more emotionally manageable for the person in front of them, okay? One thing I love is the trauma-focused CBT. It really recognizes that symptoms oftentimes are not maintained only internally, but also relationally. So it has a big focus on family response, a big focus on caregiver anxiety, right? Accommodation behaviors that loved ones make, right? So from a transdiagnostic perspective, right? Because that's what this is all about. Trauma-focused CBT can be very powerful because it targets shared maintaining mechanisms of avoidance, fear conditioning, right? Emotional dysregulation, relational insecurity and disconnection, right? And then maladaptive cognitions, right? So that is what makes this particular model, again, highly adaptable for complex trauma and for other presentations, okay? So For many clients, especially those that have high emotional reactivity, right? Development trauma, or they have a limited coping capacity, right? The nervous system needs to first be supported with regulation, with predictability, and with emotional tolerance. And so that's why TF-CBT really places that strong emphasis on the coping strategies and building that to create stabilization. So you'll notice that that's one of the differences, right, between TF-CBT and CPT, for example, right? CPT doesn't necessarily place that emphasis in those initial phases in the way that TF-CBT does. So a perfect example of how you have two different models that are targeting trauma that diverge in different ways, but again, are also targeting those maintaining mechanisms in the same way, right? So similar, but also have their own flavors, if you will. All right. So those are our trauma models. So now you have an understanding of those and how they attack those maintaining mechanisms. And again, you can see how they complement each other. But now we're going to switch gears and we're going to talk about my fave right now. I think as clinicians, we all like bounce around. We have, I'm really into this one right now when it comes to models and therapeutic interventions. I've been on one for RO-DBT for a while, so I'm really stoked to talk about RO-DBT. If you're not as familiar with RO-DBT, get familiar because it's fun. It's really fun to do, and it's just a fun intervention to experience with patients and watch them just open up. But let's talk about it. So we're going to talk about RO-DBT and how over-control can play a role, right, as a maintaining mechanism. It's important to know before we dive in here, I do want to say over-control is frequently missed a lot of times, right? Well, think about it, right? Over-control can actually look very much like stability, right? It can very much look like compliance, right? And it can very much look like someone who's high functioning. Shocker, if you've worked with eating disorders, some of our most severe eating disorder cases are folks that have the highest GPA of their class. Scholastically and academically, they are at the top. Athletically, they are still performing the best, right? And that is why pathology can go overlooked for so long, right? When we're talking about trauma, this really does clinically play a role also because trauma work can easily stall when we have over-control present because over-control is going to block vulnerability, right? And over-control is going to block emotional expression. So let's talk about RO-DBT. So radically open DBT, it differs from standard DBT in a very important way. So the primary target of RO is not emotional under control like a standard DBT, but specifically honing in on maladaptive over control. And over control is going to look like patterns of excessive self-control, right? Emotional inhibition, those patients that are highly perfectionistic, very, very rigid, very detailed oriented, risk averse, if you will. And these folks oftentimes experience intense emotional loneliness. And you'll see that in the literature when you start to look into RO-DBT. Again, these individuals can look highly functional externally, very organized, very achievement oriented, right? Very responsible. But it's interesting because these folks experience internally profound isolation and profound anxiety, profound shame, and disconnection. So RO-DBT is going to propose that psychological health is not defined by just symptom reduction. It's not defined by just control, but by three broader capacities, okay? So let's take a look at that, right? I'm sure we can all think about clients who've been in our office that present with over-control, right? We have an understanding of what that can look like. The three areas that RO-DBT look to target are openness, flexibility, and connection, okay? A hallmark that's really important to highlight within over-control is emotional inhibition, okay? Because rather than just openly expressing emotions, these individuals have a tendency to minimize. They also have a tendency to intellectualize or even conceal their emotional experiences. Their affects can appear quite flat or restrained when you engage with them. They're highly controlled, right? Even when they're experiencing significant distress internally. And that can create such a clinical mismatch, right? Which can be really confusing because a person can look really calm, but then feel profoundly anxious on the inside or super ashamed or very lonely. So Important to note that folks who are struggling with over control, when we give them feedback, feedback can honestly feel very threatening, right? Rather than collaborative here, because what's it doing, right? It's activating fears of failure. It's activating those fears of inadequacy, right? Or loss of status. Like folks are going to see me. I'm not going to be viewed as quote unquote perfect, right? I'm going to look imperfect. Another important point that over control often involves is threat sensitivity, right? We've talked about threat sensitivity in the trauma lane, right? But threat sensitivity is huge here. And oftentimes it's masked by competence, right? So instead of more like obvious dysregulation, threat sensitivity in this population, when we're talking about over-controlled folks, can look differently. It can look like excessive preparation, right? Emotional constriction. Think about your patients that have, again, that hyper responsibility almost, right? Like everything is just too organized and too outlined, right? You've seen these folks. They come into your office with their day planner and there's 10,000 tabs all in different colors that are all labeling different things and different highlight colors that represent different categories, right? You've seen it, These folks, also importantly, oftentimes you'll find they deeply desire closeness. They deeply desire connection, but they struggle. They struggle to signal openness and vulnerability to other folks. And they struggle when it comes to being emotionally accessible, right? In ways that are needed to foster like honest connection. So RO-DBT is really focusing heavily on those three domains of openness, flexibility, and connection. And treatment is not about reducing responsibility or reducing discipline, but it's about helping these individuals loosen up, right? It's allowing them to see that it's okay to loosen that control that they have. Because when we do that, it honestly increases their ability to be authentic, right? And connect genuinely, have relational reciprocity, if you will. So that's why I say it's fun, because working with someone and using RO-DBT, it's almost like you're helping someone learn how to get outside of themselves and how to laugh and how to have fun and how to loosen up. And so that's why I love it so much. Let's talk about the mechanisms within RO-DBT. So RO-DBT targets the three areas that I mentioned before, and those are the three big mechanisms. The first, it's going to target low openness, okay? Think about it. This is obvious. Over-controlled folks really struggle. They struggle to take in feedback. They struggle with uncertainty. They struggle with anything that's going to challenge beliefs or routines that they know and that they feel strongly about, right? There's frequently a strong need for correctness, right? And for predictability. Because think about it, right? What does structure give us? Structure gives us safety, right? And that applies to all ages, all folks, right? Structure is safety. So when we provide feedback that may conflict or contradict with something that a folks who's that an individual who is very over controlled may have, again, it can feel very threatening. So that might look like a defensiveness. That can look like those perfectionistic tendencies coming out even stronger, right? Rigid adherence to rules and expectations and no wiggle room. RO-DBT is going to work to increase that openness, right? Openness to new learning, openness to experience. The second mechanism here is low flexibility, right? We've talked about the rigid routines, right? You have folks who are sitting in front of you. I can't make a B, right? How many teenagers have you worked with that are over controlled? I think of myself in school. I put a lot of pressure on myself in school, but I think of myself, we'll say in college. I was a little looser in college when it came to academics, but thinking about a B is fantastic. If I got a B, I was like, we're rocking and rolling. For someone who's struggling with intense over control, though, the thought of getting anything less than a 98, 99%, or even 100% is earth-shattering, right? So we want to help these folks loosen that excessive rigidity, right? And just develop greater emotional flexibility and behavioral flexibility, right? We'll oftentimes use interventions like, I want you to not turn in a homework assignment just once. Just don't turn it in. Or I want you to leave a question blank on your test this week so you get that one wrong, right? It's catastrophic. It's catastrophic for some of these folks. But these are some of those things you can challenge folks with so that they can see like, hey, I can do it. Everything's okay, right? I can sit with it. The third mechanism is going to be that low social connectedness. This is a major focus of RO-DBT, and also probably another reason why I love it, because I think connection is just such a huge just need for our psychological well-being. But individuals who are over-controlled, they will oftentimes unintentionally communicate distance, right? Their facial expressions, their tone that they use, right? They might kind of signal like, do not approach me, do not talk to me, even when they deeply desire closeness and they deeply desire, a friendship or connection. So it's not uncommon for folks who are over-controlled to really experience that chronic disconnection. And that leads into the final mechanism here, which is emotional loneliness, right? Emotional loneliness is not just simply being alone. It's the feeling of being like fundamentally unknown or fundamentally being unseen. So many over-controlled patients will talk about feeling emotionally isolated, even within relationships, because they just struggle to relate and to connect. So these are the mechanisms that are targeted by RO-DBT. Again, think about how these mechanisms appear across different presentations, right? This sense of over control actually is present in more diagnoses than just perhaps eating disorder, right? More than just OCD, more than just anxiety. Fun fact when it comes to RO-DBT was actually developed looking at folks with treatment-resistant and or refractory depression by Dr. Thomas Lynch. So just an interesting nugget. It's a fascinating intervention and it's fun. Social signaling is a big piece of RO-DBT. So I want to take a bit to just talk about social signaling. And social signaling specifically is looking at those subtle interpersonal cues, right? We talked about how folks that are really over-controlled sometimes can inadvertently just push people away, right? Or put up that wall. So part of the treatment within RO-DBT is working on social signaling to help individuals understand themselves, right? And how to best communicate, understanding their facial expression, understanding their tone, their posture, their eye contact, their body language, right? Because these signals are really, these signals are really what allow folks to approach us, right? They shape individuals' experience of us, right? And so we want to be emotionally available in relationships. And so RO-DBT really targets this, okay? It really emphasizes that social connectedness is not always just what we say verbally, it's how we present. Sometimes I'll get folks that'll say, oh, but Lacey, in social signaling, are we trying to teach people to be inauthentic or to just be, quote, happy all the time? Absolutely not. We don't want folks to be inauthentic. Everyone has their flavor and we need that, right? Like that's what makes relationships so special. We don't want anyone to lose a sense of themselves, but what we want is for folks to just be aware. We want that awareness to be there of how you come across and how, if you're hoping to engage in a different way with someone, how you can do that effectively, right? So it's not about being inauthentic or putting on a show or being performative at all. So the relationship between trauma and over control is pretty heavy, right? For many patients, over control doesn't just develop randomly, right? It develops as an adaptation to environments that have felt unsafe, right? Or environments that have felt unpredictable, environments that have been emotionally invalidating or dangerous, right? And trauma can teach us very powerful lessons about the world and about just the self in general, right? Vulnerability can oftentimes become associated with danger, and emotions can feel unsafe or overwhelming. And so the patients that we work with can very easily start to learn things like if I stay composed, then I'll be safe. Or if I don't lean on anyone and I don't need anyone, then I can't be hurt because I can just rely on myself, right? Or if I don't make mistakes, then I can avoid criticism, right? We see it pop up. Over time, these are strategies that become very deeply rooted and deeply reinforced. And again, it's important to note these these patterns very well work in the short term, right? Over control can be very successful. It increases the predictability, right? It increases certainty. It increases achievement, right? So that's why RO-DBT really works to emphasize that over control is not simply pathology, right? It truly is viewed as like an adaptive survival strategy, right? That just becomes too rigid over time. And that's a critical therapeutic stance, right? It's important to note if we move too quickly to challenge control without really understanding what it's doing for a patient, that can be very dangerous and very threatening to someone, right? We need to understand the protective function of over control, right? We must first honor and validate the purpose of it. That's really important, right? I think that also can really help build rapport with folks when we allow them to understand and we acknowledge, of course, these strategies develop for you. Of course, they help you to survive. They help you to feel comfortable, right? Therapy can really only be effective when we have that connection with someone and the ability to truly engage with them at a therapeutic level. And so I think especially as we're working to challenge someone's over control that they are using like a security blanket, we have to understand where it's coming from. And even if we don't agree with it, right? Similar to any maladaptive behavior, right? Or coping strategy, you name it, we don't have to agree with it, but we certainly can acknowledge that it's doing something for the person sitting across from us, right? And acknowledge that it's serving a purpose and that we understand, right? Again, we may not agree, but we at least understand, right? So things to keep in mind. The goal, again, is to just truly loosen that rigidity. And that's why the RO-DBT target zone, if you will, on the right, that's here on your PowerPoint, it really emphasizes that there's such an overlap. There's such an overlap between openness and flexibility and connection. And from a transdiagnostic perspective, trauma-related over control can appear across many presentations. Think about it, guys. It can pop up in eating disorders. It can pop up in chronic anxiety, in obsessive compulsive disorder, in chronic depression, right? So it truly can pop up and present in multiple areas. And again, that's why transdiagnostic treatment is so fantastic. And thinking about mechanism-based care is so cool because as we focus again on the mechanism, on what's underneath, not just the symptoms, but what is driving the symptoms and driving the suffering, we have the ability to target multiple things at a time versus if we stay in one lane at a time and only focus on symptom reduction. Okay. I think we've pretty much gone over this, but just again, these processes, the low openness, the low flexibility and connectedness, again, we see it all over the place, right? What ties these folks, or excuse me, what ties these presentations together, where it's OCD, whether it's PTSD, whether it's eating disorder, right? Again, is the mechanism underneath. There's a pattern, specifically when we're looking at trauma or eating disorders or OCD, there's a pattern almost, right? You can think of like a pattern of constriction. There's a pattern of isolation, patterns of inhibition, excessive control that are fluttering underneath all of those, right? And that's why, the final point on this slide is really important. RO-DBT is especially useful when symptoms are maintained more by constriction than chaos, right? It's a really important way to view it. When symptoms are maintained by constriction versus chaos, right? These clients are not often impulsive. They're not often behaviorally dysregulated, rather. They're tightly controlled. So traditional approaches sometimes miss this. They miss the over-control piece because a person doesn't look dysregulated. They don't act dysregulated. But internally, there's a different story going on. So that is RO-DBT. I want to move to talk about the integration through mechanisms for the next kind of section. And then we're going to go through a case conceptualization together just to kind of wrap our heads around how we start and how we look at this through a treatment lens and what we do first, what we do next, right? One thing to remember is when we talk about integration, it's really not permission to just like do a little bit of everything. It's really important that as clinicians, We identify a dominant maintaining mechanism, and then we choose the model that best addresses it, right? So we sit down with the patient, we get that full picture of what's going on, and then we look for those mechanisms or themes. Again, we're not working to tackle everything at the same time. We're looking to just target where can I see movement now, right? Where can I make a move? We just select that mechanism, and that's where we start. And we're going to pair that with a model that targets that mechanism. And then we're going to continually reassess whether that treatment is working, whether we're seeing movement. Okay. So looking at the comparison, we just went over these three models, and these are the areas that are typically focused on, right? When we are looking through a lens of clinical integration, right, we are asking what mechanism is most maintaining the suffering today, okay? What mechanism is maintaining the suffering today? This is probably one of the, even though it's pretty minimal, but it's one of the most important ideas in the entire slide deck. Although these three modalities look different on the surface, right? They overlap significantly. Okay. Each model brings a different emphasis, right? Remember, CPT is all about meaning making. TF-CBT is all about the skills, regulation, exposure, and then RO is all about the openness, all about increasing flexibility, right? Underneath those differences, though, you will find that they are all three working on similar clinical goals, right? And that overlap is shown in the shared targets box. They are all targeting avoidance. They are all targeting shame. They are all targeting rigidity, and they are all targeting safety learning, right? So examples of this. CPT. CPT challenges those rigid trauma beliefs and shame-based meanings, okay? TF-CBT works to reduce avoidance through exposures. RO targets emotional inhibition, right? And rigid self-control that maintains disconnection. These are all different pathways, right? But those different pathways have the same underlying mechanism, okay? So we're going to go back, think about at the beginning of the presentation. We're no longer thinking, well, what diagnosis equals what treatment? We're asking what is keeping the person stuck? What mechanism is most active, and what intervention can I use right now that will unlock some movement, right? It's important to note for one patient, that movement could come through cognitive restructuring. For another, it may be, I need to focus on emotional regulation right now, right? This framework really, again, it keeps us as clinicians very grounded in these evidence-based practices, and it allows us to adapt flexibly, which I think is fantastic. So when we talk about sequencing, sequencing is the bridge between formulation and treatment, okay? When we think about effective care, it's not only about choosing the right intervention, it's really about the right intervention at the right time, right? So many clinicians, not saying any of you guys out there, but many clinicians will just ask themselves, like, well, what model do I like best, right? Oftentimes, that's not going to say the wrong clinical question, but it's not the best clinical question, right? A more useful question is, what must shift in this person's life first so that the next intervention can work, right? That's the essence of sequencing, right? So for example, if you have a patient that's highly dysregulated, they experience a ton of emotional flooding, right? They're unable to tolerate any distress. They jump immediately into big emotional episodes, if you will, right? Jumping right into trying to engage in cognitive restructuring, if you will, probably not the best approach, and it likely will fail, right? They're just not there yet. If they're highly dysregulated and unable to regulate themselves in a manner to be able to access the areas of the brain that are needed to think logically, right? That's not setting up the patient for success. So in that case, right, think about a model that might be useful based on the three we've just talked about. If you're thinking about trauma-focused CBT, you're absolutely right, because the first stages of TF-CBT are stabilization, right, and really working on that regulation work, and that needs to come first. If we have a client who is extremely rigid, right, intellectually, they're very insightful. They say all the right things. They're quite smart, right? But emotionally, they're so disconnected. And insight alone may not create the movement you need, right? Think about RO-DBT, right? Cognitive restructuring, cognitively, they know what to do, right? They're intellectualizing things and they're very rigid, right? So RO-DBT interventions that target the openness, right, and target social signaling, that might be necessary before we move into trauma processing, right? If avoidance, let's think about avoidance. If avoidance um, has decreased, for example, and a client is more emotionally available, CPT might be a good option because CPT becomes really effective for our adult patients at targeting stuck points, right? At targeting shame and trauma-related meaning, right? So it's really about matching the intervention and matching the model when the time is right. Okay. And again, asking those questions, what's maintaining the symptoms? What capacity is missing? What intervention is going to prepare this patient to effectively move to the next layer of work, right? And that's why the slide that you see in front of you looks at clinical sequencing as very much like a clinical safety issue. It's not just therapy preference, because when we engage in poor sequencing, it really can set the patient up for failure, and it can overwhelm clients. So things to keep in mind. So some decisions to think about when you're working with the patient. Can the client actually access emotion in a meaningful and workable way, right? That's going to be decision point one. Decision point one, okay? If a client can't feel or they can't identify or tolerate, trauma treatment can easily become overly intellectualized. The work can stay very cognitive versus emotionally integrated. So we always want to ask, can the client access emotion? The next decision point is thinking about, is avoidance that the patient is experiencing, is it cognitive, emotional, behavioral, or relational, right? These are different in their own way. And it's important that we understand how this is showing up. Avoidance is not just one thing, right? Like there's different forms of avoidance and they require different pathways of intervention. And this is why sequencing matters so much, right? If we mismatch the intervention to the mechanism, treatment can stall, right? It can even reinforce the avoidance. So important that we ask those important questions and delineate where avoidance is showing up and how, since it's different. The third decision we want to make, what is the function of control, right? What purpose is control serving for the person in front of us? Before we ask someone to relinquish control or loosen it, we have to understand, what does the person in front of us believe that the control that they have is preventing, right? Because that's going to give us insight into why it's so safe for them, right? The goal is never to strip away control entirely. And it's important that we let our patients know that, but we have to understand the function of control, right? And then our fourth decision point, always keeping in mind, what does the alliance need? What does the therapeutic alliance need? Okay. Over-controlled clients oftentimes experience relationships as more formal, for example, more evaluative, more emotionally distant, right? They can appear very highly composed and very collaborative. So in these cases, warmth, humor, right? Humor is huge. Playfulness is huge. The literature on RO-DBT talks about when we're looking at RO-DBT and the therapeutic alliance, it's important that the therapist model the playfulness and that the looseness, if you will, when it comes to the rigidity aspect that we want in our patient, right? We want to model that for them. Highly traumatized patients, right, oftentimes need very much, they need the predictability. They need the transparency. They need the very methodical pacing of sessions. They need a lot of choice, right? So it's important that we understand, what does the alliance need as well for patients, okay? What you see here is not a rigid protocol at all. It truly is just a conceptual map, if you will, for sequencing treatment, and it's based on mechanism, right, versus diagnosis alone. So really moving through your sequencing, making sure that patients are hitting these areas successfully, because we want them to be able to move through the sequence of treatment in a successful way. Also important to note, this is not always linear. A clinician can cycle back and forth with the patient through this. It's not uncommon for patients to sometimes move backwards, right? If there's high risk, or move backwards if there's dysregulation or constriction increases, that's okay. But we want to make sure that we are always moving, right? Stabilization and safety. This is where trauma-focused CBT can work wonders, right? Second phase, opening emotional and social access, right? Thinking about it in this vein, RO-DBT can be helpful here to really increase that openness, increase flexibility, work on the social signaling piece. Without emotional access, again, remember, trauma work can become just very intellectualized and lack the emotion that's needed to fully heal, right? The third phase, the processing and the meaning making and the stuck points, what does that remind you of? CPT. That's where we get into very meaty, processy work when it comes to the trauma in and of itself, okay? So moving through each of these phases as we sequence treatment will, again, work to set our patients up for success. Okay, so let's talk about case application. I'm being mindful of time here. I just want to make sure that we get to everything and we have some time for question. I want us to talk about a case together and kind of break it down together. So let's all meet Amanda. Amanda is a 27-year-old patient. She's in eating disorder treatment. Amanda is struggling with restriction, chronic anxiety, childhood trauma. She's high achieving, she's guarded, she's very perfectionistic. She rarely appears dysregulated in session. The calm presentation that she has is clinically important, right? It can lead folks to underestimate her risk, right? Her distress or her loneliness. So keep that in mind. Amanda reports feeling defective. She reports feeling terrified of needing others. Trauma reminders increase restriction for Amanda. She has a history of trauma, remember. She typically overworks. She engages in withdrawal. Her eating disorder behaviors are not just about food and weight. They also function as control, numbing, identity coherence, okay, and avoidance of vulnerability, all right? So for those of you who work in the eating disorder field, this probably reminds you of many patients that you engage with, right? Thinking about Amanda's presentation here, you guys, and what she's bringing to the table. We have anxiety, we have eating disorder, we have trauma, right? All three lenses that we have talked about, cognitive processing therapy, trauma-focused CBT, and RO, right? They can all be utilized here. CPT for meaning, right? Trauma-focused CBT for handling those trauma reminders and the approach, and then RO-DBT for the overcontrol and the emotional loneliness, right? So thinking about an initial formulation, okay, and how we would do this from a transdiagnostic model, utilizing these three interventions, right? The initial formulation, we're going to integrate language from all three models here. So from a trauma lens, we can understand that Amanda learned that vulnerability led to danger or humiliation, right? So from a CPT lens, we could identify that her stuck points include needing others as a weakness, right? Her stuck points may include my body is unsafe. If I lose control, I will fall apart. Okay, those are some core stuck points. From an RO-DBT lens, restriction, emotional masking, perfectionism, withdrawal, over-preparation, right? Those are all reflective of over-controlled coping. And from a trauma-focused CBT lens, we know that trauma reminders really activate avoidance for Amanda, and they activate safety behaviors, right? So when we formulate a patient, it's important that we formulate the symptoms as understandable rather than pathologizing, right? And we look at them through the lens of these models, okay? So that's our initial formulation. What not to do first is to assume that Amanda's calm presentation means that she's ready for that intense trauma work, right? Remember, just because she's composed, it doesn't mean that she is not disconnected, and it certainly doesn't mean that she's not over controlled. Okay, so we really want to make sure we understand that. Second, we don't want to confront the control, right? Until we understand what it's used for and until we validate, right? Its protective history. If control has helped this girl survive, it will likely increase, attacking it is going to likely increase threat for her. So we need to make sure that we give her that understanding and we ensure that we validate that it does have a protective history and it has served a point, right? Third, we don't want to rely solely on cognitive insight, right? Because Amanda may be excellent at worksheets and she might be great at explanations, right? She can still be really emotionally distant. So we don't just want to immediately move past that, okay? And finally, we don't want to confuse compliance with engagement. Just because she's showing up, just because she's answering questions, right? We have to make sure that we are really honing in and making sure that she is emotionally present, right? And we want to do our job as clinicians to track a little bit. Is she becoming more flexible? Is she able to do that? Is she able to increase her emotional presence? Not whether or not she can just say the right things. Okay, so just some important caveats to keep in mind as you're meeting with the patient and you're thinking about those initial formulations. When we think about the initial treatment priorities, early treatment for any patient should really be about focusing to create enough safety and emotional access for the deeper work to matter, right? So the alliance needs predictability, absolutely. Your alliance is going to need warmth. We all know this. We're all providers, right? And we also can look through these different lenses, right? So RO-DBT informed work can really help Amanda to notice those over-controlled coping styles, right? Practicing emotional expression, experimenting with warmer social signaling to build connection, right? Looking from a trauma-focused CBT lens, right? We can use regulation skills to help her tolerate trauma-linked affect, right? Without immediately returning to withdrawal or immediately returning to isolation or restriction, right? And then we can use CPT work gently by identifying stuck points once we know that Amanda has developed and has the appropriate regulation skills to manage in an effective way. But we wouldn't want to rush the formal trauma processing portion before she has the capacity, right, to stay present, to be emotionally available, and to be connected. And that's why all of these modalities, they intertwine and work really beautifully together, because you can't necessarily have effective CPT process work without a patient being emotionally regulated or know how to regulate themselves, right? And that's a TF-CBT kind of skill, right? Or intervention, really working to build those skills. And you can't necessarily work on emotional dysregulation until you have someone who understands their emotion and is willing to be emotionally available and loosen their rigidity. And that's where RO-DBT can come in handy. So you can see how these intertwine and they work really beautifully and kind of bounce back and forth between each other, right? Which makes sense as we know after reviewing each of them, right? They're different interventions, but they target those same mechanisms. It's like opening up the cellar door and going underneath, right? No longer are we looking just at symptoms. We're looking deeper, okay? So that's your initial phase. The middle phase integration, right? After we start working on those very, very first aspects of treatment, right? Really just focusing on the initial layer. The middle phase, the clinician is going to become more active in the processing. So then we're going to move further into CPT, right? We're really going to work to understand the beliefs that have been developed about blame, about defectiveness, right? Because she indicated she felt defective, about control, right? Here's when we can pull in some of the exposure work too from trauma-focused CBT, right? We can use the graduated exposure when it comes to those trauma reminders that we know kick off symptoms, body-related triggers, right? And we can continue to supplement with RO-DBT, just making sure the work doesn't become purely cognitive, right? So continuing to have Amanda practice openness and flexible responding, right? Continuing to assess social signaling and work on the connection piece, right? Eating disorder behaviors are not lost in this. It's important to note as we continue in treatment, we still want to track those, but it's important because we can track those and use those as data for avoidance and control strategies, right? No longer are we just looking at a percentage or how much a person is completing. We are looking at and conceptualizing the behavior again as avoidance or control strategies, right? And that's what's keeping the treatment integrated, right? We are targeting mechanisms here. And if we know that those symptoms are a result of driving mechanisms, right, it really changes the way that we view treatment in general, right? So again, this is your middle phase. We're getting a little bit meatier, but we're still utilizing concepts from each domain to target different areas, right? Different symptoms, but that all serve the underlying mechanisms, okay? And then your later phase integration, right? Here's where we really move into just generalization of flexible responding, right? Having Amanda practice new responses in real life contexts, right? So that could look different. That can look like meals with other people. That could look like taking feedback, right? Making mistakes, tolerating relational closeness, right? Relapse prevention happens here, really focusing on patterns that could pull Amanda back into rigidity, what those look like. What do shame spirals look like for you, right? Trauma anniversaries. The goal is to formulate an identity beyond symptoms and control, right? We want to move into accommodation here. The trauma remains part of the story, but it no longer organizes the whole life, okay? All right, so this is just, this slide I think can be helpful. We're going to send all these out, these slides too. This is just what is referred to as like an integrated mechanism map, and it kind of walks you through just the process of whenever you have a patient come through your door and you're working on integrated treatment, and just questions to ask yourself, things to think about as you're working to understand the patient in front of you, right? Identifying the present symptom, making sure we understand the function, linking that function to a maintaining mechanism, choosing a model that best targets the mechanism, and then reassessing movement, right? Not just basing it on what the patient is saying, but actually examining evidence of improvement and movement in your sessions, okay? Some model matching questions that can enhance your practice, right? When we're talking about CPT, what belief is keeping the trauma active? Right? A good trauma-focused CBT question, what skill, exposure, or safety step is needed for tolerable approach? Right? RO-DBT question, where is control in this individual's life? Where is it blocking openness? Where is it blocking flexibility, right? And then from a transdiagnostic perspective, always asking what mechanism is most costly right now? Because that's where we want to target, right? And you can even change your own language. We certainly do this at SunCloud. We change our language a bit because it's important to always understand how the language that we use can oftentimes come across in ways that are inadvertently maybe not demeaning to patients, but I don't know, casts a different light on a patient's needs. So, for example, rather than using the term attention, a patient does that for attention. We don't use that word here. We use connection, right? Because that's what the patient is seeking, right? Another way to think about this from a transdiagnostic lens, instead of saying like what diagnosis is primary, even using different language with your teams and with folks you interact with to really hone in on, well, what's maintaining the suffering, right? What's the next measurable treatment target, right? What's the mechanism, right? When we introduce that language just into the way we do our work on a daily basis, we start doing it inadvertently and we start conceptualizing it very automatically. So just something to consider. It's something that we really value here. I also have a slide here on fidelity guardrails, and this addresses an important ethical and clinical issue when it comes to integrative treatment work in general. Folks will often say like, well, how do we integrate models thoughtfully without losing fidelity, right? As we become more flexible and transdiagnostic in our thinking, there can sometimes be a temptation to just like blend interventions in a way that becomes really vague or inconsistent. And we don't want that to happen. So it's really important. And this slide is just going to highlight just different guardrails you can use that help really maintain the integrity of the work that you're doing and the effectiveness of it, but always being very mindful of how we present things too, right? So when we say we're delivering a full evidence-based protocol, That is very different than when we say that we're using a model that's, informed interventions, that's integrated into broader treatments, right? Those are two very different things. So instead of saying we're going to do CPT informed work, or instead of saying we're doing a CPT protocol, making sure to say, we're doing CPT informed work, right? Using that language, being really transparent about the distinction. And secondly, we really want to avoid just mixing things, right? Mixing interventions in a way that dilutes the active ingredient. We want to keep the active ingredient, right? Every evidence-based model has mechanisms that it's designed to target. And if we think about it, if we interrupt exposures, right, by repeatedly giving a patient reassurance, right, we're missing it. We're diluting that active ingredient. If we shift away from cognitive processing, the moment that a patient starts to experience distress, we lose it, right? Our integration should really be purposeful and it should be thoughtful for its own sake. And then we always, informed consent obviously is essential. Clients should understand why we're doing what we're doing. Clients should always understand that discomfort can happen. And then obviously, consultation and training matter as well. So we want to make sure that we're continuing to enhance our learning, just like you're doing today, and using this in supervision and using, your knowledge of interventions and understanding of interventions and integration in the work that we do in a thoughtful way. Okay. Lastly, of course, good documentation. But these are just some fidelity guardrails because these questions do come up, especially when we're integrating. So yeah, these allow us to remain flexible, but also disciplined, which is always important. Okay. We talked a little bit about treatment team language, right? Again, this is mechanism-based language, and I think it's fantastic. It's great for teams. So instead of using terms like she is resistant, right? We could try saying things like, well, control is the safety function here. So she's over-controlled, right? Mean the same thing, but come across very differently, right? Even using term like he will not open up to me, right? Using language like, well, emotional inhibition is really, that's a huge function of his loneliness, right? That's maintaining his loneliness right now. So just thinking of the language that we use and including the mechanisms that you identify in your own case conceptualizations in the way that you describe patient symptoms and patient presentation. Again, I think it's just helpful. It's helpful in our team. It helps shapes clinical stance. When our teams can name function, they're less likely, right, to engage in power struggles with patients, right? They're more likely to intervene strategically with patients because they're understanding them at a different level, especially if we're just using mechanism-based language on the daily. Okay. So as we wrap up, I want to go over some common pitfalls. We've talked about these already, but I'll just breeze through these. Pitfall number one, mistaking over control for stability. We've talked about this, right? So making sure that we don't always just take those clients who appear calm and articulate and compliant as folks that are doing quote unquote well, right? Because for some clients, appearing okay is actually part of the symptom pattern. So we want to make sure and not miss that. The second, we don't want to process trauma before they have the capacity to do so, right? So really understanding where patients are at emotionally and their ability to regulate and withstand distress, okay? We don't want to get too heady. We don't want to get too cognitive, right? This is really common when we have highly over-controlled folks who are really bright and who are really articulate and skilled and very insightful. So cognitive work matters. It absolutely matters. But when we're looking at integrated care, it must translate into emotion and it has to translate into relationship and behavior, okay? And then four, don't lose that active ingredient. Keep the flavor, keep the meat. Very important. Okay. So I made it through. Questions. We only have a couple of minutes, which I'm so sorry, but questions.
First question, Lacey. Oh, can you read the questions?
I
No,
can't.
go ahead, Diane.
I
Okay.
can't see a thing.
Okay. First, it says, I know that mindfulness is a pillar for regular DBT. Does it play a role in RO-DBT as well?
Absolutely. So when we're thinking about over-controlled folks, think about the most over-controlled, like super rigid people that you've been around. Their ability to let go and ground themselves and be fully present, it's very hard because where are they all of the time? They're in their head, right? And so mindfulness absolutely plays a role in RO-DBT. And I think that that is an intervention that will work very beautifully to help folks loosen themselves, right? That's one of those interventions we can use. So absolutely. Yeah, good question.
Okay. And next question. Thinking about a client with a lot of just right mental compulsions understood from an anxiety and OCD framework, stuck in avoidance due to significant intellectualizing, shame around not able to just do it. RODBT sounds like it would be such a good fit here. How do you see it blend with ERP work?
Ooh, first off, yay. RODBT would be
Mhm.
fantastic for this person. Absolutely. So RODBT would really work to just shake up and loosen that rigidity a bit. RODBT is really going to hone in on the over control, right? It's going to challenge the rigidity. You're doing exposure work, right? So I think what you want to make sure of, let me see. Let me see. I've got so much in my head right now. You want to make sure, right, that there's the emotional regulation techniques and strategies that are available, right? We want to make sure there's capacity, even in the exposure realm, so that the patient can manage themselves appropriately. And important to note that since there's so much over control present, the patient's likely going to want to revert to over controlled strategies as they engage in exposures because that's what's safe for them. So making sure that you're tying that into the work, right? Having the patient recognize those aspects of over control and then even catching themselves in the exposure work and tying those things together, that will be huge for them. So, yeah.
Hey, and here's another question. You mentioned an intervention in RODBT, like having a client leave a question blank on a test. How would you approach this with the client, and when would not be a good time to do this, even when you can see they would need it?
Yeah, that's a good question. Okay, I'm a big believer of rapport, and I think, and that's a clinical judgment piece, right? Are you going to do that on like session 3 or 4, even 5 or 6 with a patient? No way, right? So this is an intervention that you can use and you can challenge. Once you've built like a healthy rapport with someone, they're able to recognize their struggle with perfectionism. They're able to recognize, right? This is taking that a step further. So a lot of the initial work that you're going to be doing with the patient is really building insight and awareness into how that over control and how that perfectionism is not serving them. And that's going to take a minute, right? And even when you get to a point where they can see, okay, well, maybe it's not serving me in the best ways, they're still going to want to hold on to it and they're still going to think that it's serving them. So it takes some time. I think you can even start smaller and like different things. I'm trying to think of like some smaller things. We've had, um, if you're in a group-based program, we've had folks like write something on the board and intentionally misspell it and then go sit down and have to sit with it. And that's really uncomfy for them. You can even, I mean, it just depends, right? So you can even challenge your patient. I don't know if they, I don't think kids write notes anymore, but in text messages, right? Like misspell a few things in text messages and send it out, and you have to sit with it, right? Or things like that. Just getting savvy about engaging in things that challenge that perfectionism. The school piece is a hard one because academics is so ingrained in some of these folks. So it's kind of case by case. That doesn't answer your question at all. But it's what I got. I think it's really heavily based on rapport and then start small. I wouldn't maybe start with the school one, I'd build up to it.
Okay. Well, we have another one. It's more of a comment. No questions from me, but I wanted to say very good job, exclamation mark. So,
Thank you to whomever
yes.
that was. Thank you so much. It has
Yeah.
been a pleasure. All right,
Yeah.
I'm going to move the slide there for you guys.
And just a reminder, thank you everyone for attending today. We're right at 1:33, so a little bit over, but hopefully you can all get back to your daily routines. And thank you so much. Just seeing lots of applause and claps, and hearts. Thank you. We appreciate it. And be on the lookout for the email that will have the instructions for getting the CE. There will be a quiz. And also, if you have any other questions, you can always contact myself or my colleague Autumn Alman, who's also on here, listed on here. We're both the outreach representatives for SunCloud Health. So if you have a client that you think might benefit from the treatment that Lacey described that we do at SunCloud Health, we'd be more than happy to discuss them with you. And so, once again, thank you all very much and hope you have wonderful weekends. So, thank you, Lacey.
Thank you guys. Have a great day.